All right. We'll quickly go through these UTIs. Remember, UTIs in themselves, problematic, yes, but the real problem comes in when the infection regurgitates up from the bladder into the kidneys, right? Up through the ureters into the kidneys. That's when you get really bad problems. So when we talk about lower UTIs, we're talking about cystitis, but that pyelonephritis is what you really want to watch out for. So Staph aureus, big problem. Typically, females have a shorter urethra, so they have a higher prevalence of UTIs than males. But what you'll see is Staph aureus is there. Some of those Enterobacteriaceae classes, this Staph saprophyticus and Enterococcus species, they can cause it as well. But think about these when you do think about it, these gram-negative rods. E. coli, Klebsiella. Proteus is big. When you think about Proteus, you need to think about stone formation. So these are all going to form urease. And anything that forms urease is going to make stones. But when they give you this situation, Proteus is the big one. It makes those huge staghorn stones, okay? All right. So we can get into, and it can lead these lower UTIs can lead up to pyelonephritis. Typically, they'll talk about costovertebral tenderness, and it could even lead to things such as papillary necrosis, which is like sloughing off of the papilla or the tubules. And you could see that here, some other complications of papillary necrosis. So if they talk about diabetes, urinary tract problems, sickle cell disease is another one, and prolonged NSAID use as well. So a lot of times they'll give you this. The one they like is they'll say somebody recently had a back problem. They've been taking, some sort of NSAID, ibuprofen every 6 hours for 2 months. They ended up with papillary necrosis. Okay, so be aware of that. Right, and right. So cystitis, frequency, urgency, burning, pyelonephritis, much worse symptoms, right? You get fever, costovertebral angle tenderness as well. Okay. Y'all have talked about this, and Lindsey's going to go through it. Post-streptococcal glomerulonephritis. They always have to preface it with they had a previous strep infection, right? Typically, this happens in kids. They usually get better right away. And again, it shows that molecular mimicry, similar to like in rheumatic fever. Okay, so you can see that here. Right. And then lower UTIs, cystitis. So lactobacillus, they are common in the vaginal canal. So they help to acidify the vagina to help with infections. Right, and this reflux, this vesico-ureteral reflux is what you're worried about when that cystitis goes into pyelonephritis. Right, like primarily when you're thinking, if they don't give you any other information, E. coli is going to be your first thought for cystitis. Catheter associated, again, E. coli, Klebsiella proteus. Those are common on the skin flora, so they're going to come up. Yeah, acute hemorrhagic cystitis can be caused by adenovirus. Yeah, not terribly important. No, the specific strain of E. coli has those standard features, those virulence factors here, lipid A. All right. Proteus, remember, like I've mentioned with Proteus, you're going to get those staghorn stones. So that's a problem. They're actually magnesium ammonium phosphate or striuvate stones and calcium phosphate. Okay, so it's a big problem. See the urease production is through the roof, and that's what's going to end up causing those stones. Staph saprophyticus, if you remember that this correlates to honeymoon cystitis, then you'll get it right. It has a right. So when they talk about this, they say, you know, people were on their honeymoon or sexually active, and it just happened recently. So you could see that they'll have negative nitrite because they are gram positive. Okay, so anything that is nitrite is gram negative. If nitrite comes up positive, it's a gram negative. So staph saprophyticus is gram positive, so it's going to have a negative nitrite. Whereas all the other stuff, pretty much all the other stuff we were talking about, except Staph aureus, is gram negative. But you can see urease production, so you can get stones. All right, and this kind of breaks it down, but y'all can look at this on your own. All right. Yeah, so, you know, again, right, this is what you would expect. Suprapubic tenderness, cystitis, costovertebral angle tenderness, then pila. All right. It's all yeah, okay. Well, yeah, definitely check this out. Leukocyte esterase, that would be positive in the presence of neutrophils. All right, so that could be indicative that there's an infection there. Nitrite test is going to test to see if there's any gram negatives there, which there might be. Anything that makes urease is prone to making stones. The big one's Proteus. All right, good. Culture it, yes, good. Here's a nice little picture. E. coli is urease negative, but nitrite, right? So anything that's gram negative, all three of these will have nitrite. Anything that's prone to making stones will have urease. Wait, did I say leukocyte esterase was, I might have said leukocyte esterase was presence of neutrophils. I think that maybe that's secondary. Maybe that's secondary to the infection, sorry. So these all actually are gonna have leukocyte esterase. I think that actually means that neutrophils will show up, but don't quote me on that. I mean, it would make sense because they're a bacterial infection. Anyway, okay, so yeah, so good here. If you have this memorized, you should be good with all the cystitis infections, Proteus, staghorn stones. All right, good, 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 good. I am done. Lindsey, you wanna knock out this pathology real quick?
Yeah, let's finish this up real quick. So since we're already talked about this, I'm not going to go into it again, but just understand nephrotic versus nephritic. So again, just pulled out the big things you need to know on here. You know which are nephrotic versus nephritic because you can tell what kind of pathology it's going to be based off of the lab. So nephrotic, high proteinuria. Minimal change disease, you're looking for a kid with a history of a respiratory infection, or if they were recently immunized to prophylactic immunization. So nephrotic, so you're going to have proteinuria greater than 3.5 grams. No hypertension, remember hypertension is more associated with nephritics. And then anasarca, which is generalized body edema, which makes sense because if we have a high proteinuria, then we don't have any protein, we don't have a lot of protein in the serum. And so you're getting a lot of fluid leaking out into the interstitium. So the three big things about the glomerular diseases are light microscopy, immunofluorescence, and electron microscope. Those are the three things that are going to be indicative of each individual one, because sometimes they don't give you like a clear-cut presentation of this is this, this is this, this is this. So normal glomeruli, they will most likely tell you that there is normal glomeruli, or they'll describe a kid with minimal change disease, and then normal glomeruli will be a characteristic of it. No immunocomplement deposition, and then the big thing is that there's effacement or fusion of the foot processes of the podocytes. Remember, nephrotic, you get damage to the podocytes, which is why you're getting all the protein out in the urine. And then something that I remember being important, this does respond well to corticosteroids. versus the next one, focal segmental glomerulosclerosis, which does not respond well to corticosteroids. So this one is more associated with HIV and obesity, chronic reflex nephropathy, heroin use malignancies, light microscopy, getting the segmental sclerosis and hyalinosis, kind of goes along with the name focal segmental glomerulosclerosis, glomerulosclerosis. Immunofluorescence that can either be negative or non-specific granular deposits of IgM, sorry guys, and C3 complement 3. EM, again, like minimal change, you have diffuse effacement of the foot processes. And then these do not respond to corticosteroids. And then many of them are going to progress to chronic kidney disease and even end stage renal disease. Once you get to ESRD, you are put on dialysis and it's end stage. And so your kidneys are not functioning, or your kidney or kidneys, plural, are not functioning at that point. Notable, the proteinuria in focal segmental is insidious. So you're not going to have symptoms initially. It's going to be later. And then it's non-selective. The proteinuria is non-selective, so you can get all types of protein. Nephrotic range, of course. And then the degree of proteinuria is going to be your prognostic indicator. Remember, this can have a really bad prognosis. It's not going to respond to corticosteroids, and then you can develop ESRD. And so the amount of proteinuria, if you're not catching it early, can be your prognostic indicator. Membranous nephropathy, again, nephrotic. So males 2 times more likely than females, more likely in the elderly. So these are going to be more, this is autoimmune. So look for the PLA2R. So against those on the podocytes. And then this is what's going to lead to the immunocomplement, immune complex deposition. So this is associated with lupus, malignancies, drugs, and infections. The biggest thing are the spike endome appearance that you can see on light microscopy and electron microscopy. And then the deposits, you need pay attention. It says granular, so versus linear, granular IgG and C3 around the glomerular basement membrane. That's also very important because some are going to deposit in different places. So when you get to these glomerular diseases, a lot of the times what's going to differentiate are just these characteristics right now. Again, poor prognosis, you're going to have a large amount of proteinuria per day. So kind of makes sense if you're in a nephrotic syndrome and you're getting all of this protein out in the urine, it makes sense that your prognostic factor would be the amount of protein in your urine because it's kind of a measure of how much podocyte damage you have. And then renal amyloidosis, they give you 2 types, primary and secondary. Know what type of amyloid you're talking about and what's associated with. So AL is with multiple myeloma, AA is with rheumatoid arthritis. Big things here, you're gonna have Congo red stain and then apple green birefringence, and then presence of apple green birefringence. Electron microscope with non-branching continuous fibrils, and then clinical features up at the top. This is going to be how you can detect it in your vignette. Okay, now we're moving on to nephritic. So you're still getting the proteinuria, but it's going to be less than 3.5 grams. But this clinical presentation is going to be associated with hematuria, so bloody urine. People are coming in, they're peeing blood, and this is inflammation to the glomerulus that is leading to this. So IgA nephropathy or Berger's. This is all mesangial, so no matter if you're looking at light microscopy, immunofluorescence, or electron microscopy, it's all deposits in the mesangium. So you get proliferation, deposits of IgA with C3, and then of course mesangium, again, deposits there. What are you looking for in your clinical vignette? A kid coming in with episodes of peeing blood. So it's episodic, so you will, they will have a peeing episode of blood, then not. If they can't see the blood, most likely you are getting microscopic blood. So it's not like it's going away, you just can't see it. But you have normal serum C3, C4. This is really important because when we talk about some other nephritic diseases, you don't have normal serum complement. And so highlight that. That's going to be something that will clue you in on this in your clinical vignette. So kid, episodic hematuria, normal serum complement. And then this can progress to ESRD. There are some associations, arthritis, vasculitis, non-thrombocytopenic purpura. I'm not going to try to pronounce that, HSP. And then they loved to, it's associated with celiac disease. So that's a common one. So, you know, gluten intolerance there. Post-streptococcal glomerulonephritis. Hopefully this will be very easy to identify because it's going to be a kid who had a strep throat or a skin infection. So now they're going to be presenting with edema. Then tea or cola colored urine, they might put that in the vignette. So kid, strep throat, now has like tea colored urine, will be hypertensive. Remember, nephritic syndromes, they commonly are hypertensive because you are increasing renin because of what's going on in the pathogenesis. So increase of renin, you're going to have retention and you are going to get your hypertension. So the kid will be hypertensive. Light microscopy, it's going to be hypercellular glomeruli, immunofluorescence, granular deposits of IgG, IgM, and C3 along the glomerular basement membrane. Remember those three, where they are. And then subepithelium humps, that's a big thing. And then to diagnose, they might either say that there are the titers in the vignette, or they'll ask you, how can you diagnose it? Because at this time, you don't have the bacteria anymore. Membranoproliferative, there are two types, type 1 and type 2. They will both present with hypocomplementemia because you are using up complement in their serum. So you're not going to have it. So they are both, type 1 is associated with the classical pathway. It's going to be IgG immunocomplement mediated, associated with hepatitis. And then both of them, you're going to have the tram track appearance of splitting of the glomerular basement membrane. But notice between type 1 and type 2, type 1, because it's IgG mediated, you're going to see IgG deposits on immunofluorescence, whereas type 2, it's not IgG mediated. So you're not going to see IgG. So you'll both still have C3, C1q, and C4, but the difference is going to be IgG in the immunofluorescence deposits. So T2, alternate pathway, circulating C3 nephritic factor, which leads to C3 activation. So if you're constantly activating C3, constantly activating the complement pathway, then you're not going to have complement in your blood. That's why you have hypocomplementemia. Okay, so clinical features, what are you going to see in your vignette? So hematuria or proteinuria on a UA, acute nephritic syndrome, of course, we're talking about nephritic. So hematuria, which is, a hallmark of nephritic syndrome, hypertension, which is also a hallmark of nephritic syndrome. And then you'll have some edema, recurrent episodes of gross hematuria. Gross hematuria, all that means is you can see it versus microscopic. And then insidious onset of edema and nephrotic syndrome. So you don't just have maybe one or the other. Some of these can progress. And so this can progress to edema and nephrotic syndrome. And then rapidly progressive glomerulonephritis. This is a rapid and progressive loss of renal function, but this is the endpoint of like other etiologies. It's not that this just stands alone. You have something else, and then you get to a point and you have rapid and progressive loss of this renal function. And so progresses to death if left untreated. So histology, the glomerular damage is so severe. Remember, it's kind of like an end stage Fibrinogen leaks out into the Bowman space, and then you get proliferation of epithelium, and that is what's forming the crescent, which is in the histo slide right there. Type 1, type 2, type 3. When you hear the word Goodpasture syndrome, I hope you immediately think of anti-GBM antibody mediated reaction. Those two terms need to go together in your head. Also, linear immunofluorescence. Up until this point, we've only talked about granular, but Goodpasture syndrome is linear immunofluorescence. And then it's a type 2 hypersensitivity reaction. Type 2, immune complex mediated. So this is more going to be your post-infectious, your IgA, your HSP. So this is all granular immunofluorescence. Type 2, essentially just know that those can develop into rapidly progressive glomerulonephritis. And then your type 3 or ANCA mediated, we've talked about those in the vasculitides. So this is coming full circle, because all of those vasculitides, the small vessel vasculitides, had presentations in the kidneys, because you're talking about the vasculature there. So Wegener's, microscopic polyangiitis, Churg-Strauss, these have no immunofluorescence. But they are ANCA mediated. So that's very high yield, very important. Remember the different ANCAs that are associated with all the different small cell vasculitides. Clinical features, I put this in here really for completion's sake. You can look over that. Okay, lupus nephritis. The kidneys, you've heard about lupus, autoimmune disease affecting multiple organs. The kidney is just one of those organs. So, there are so many things that can present from this disease, but we're just talking about the kidneys right now. I made a point to point out the ANA and double-stranded DNA. These are serum markers that you are going to be able to look for to say, yes, this is lupus nephritis. A person comes in with kidney stuff. You don't know why they're having kidney stuff. This confirms that it's due to lupus. So other things, just look for symptoms of lupus. So fever, leukopenia, thrombocytopenia, all of these things. SZ is seizure. But just look for a presentation of lupus. And then when we're talking about renal presentation, if you come in and you're presenting with renal issues, this can confirm that this is lupus nephritis. And then on immunofluorescence, everything is there. So it's positive for absolutely everything. The classes here is basically just staging of what you can see. So, you can minimal mesangial proliferative, focal nephritis. So it really just kind of builds, and it's the extent and severity that lupus is affecting the kidneys. I don't know if you guys watched The Voice. I love watching The Voice. One of the contestants was talking about how her sister had lupus and she had kidney failure, and her mom donated a kidney, but it was ultimately unsuccessful. So if any of you watch The Voice, there's your little real world tie-in right there. Okay, acute tubular injury and necrosis. So of course, now we're past the glomeruli, we're into the actual nephron where we're doing the exchange. And so if you get tubular injury and necrosis there, you're talking like major kidney injury. So most common cause of acute kidney injury. It can be ischemic. So if you have a sudden decrease in renal blood flow, so you're thinking hemorrhagic shock, heart failure, anything that's going to lead to lack of perfusion at the level of the nephron, you're going to have death of the tubular cells, and they can slough off into the urine. And that actually produces muddy brown casts because you're getting the tissue. So you're peeing out the tissue. So you see muddy brown casts. That's actually a hallmark of tubular injury. But really, you drop the perfusion there, and that's why you get sudden injury and death of the tubular cells. And then, of course, your GFR drops off significantly. Your tubular cells aren't working, so you're getting oliguria, which again is decreasing urine output. So if you have acute tubular injury, you're getting a dramatic drop in urine output. You can also have nephrotoxic, where it's due to toxic substances. So I just put the examples right here. So ischemic type, It's very patchy. So short lengths of tubules affected, segments of the PST and then loop of Henle, and then toxic, it's very extensive, which makes sense because you are getting the injury kind of as it's being filtered through, you're getting the injuries throughout the entire length of the nephron. So it makes sense that you would have extensive necrosis across the entire length. So the staging around, so initial, you're going to have a slight decrease in urine output with a rise in blood urea, nitrogen, creatine. So blood urea, nitrogen, of course, nitrogen is just a breakdown product of protein in your blood. You know, back in DM, the whole urea cycle, you have to get rid of urea because it's toxic. And then creatine is muscle breakdown. So these are normal metabolic processes. These are normal catabolic processes that are filtered by the kidney. But as soon as you affect the kidney, these are going to go up. Now, just of note that you'll talk about this in term 5, an isolated rise of BUN can just be dehydration. But if you get a rise in creatine, then you know it's at the level of the kidney. You have a kidney issue. So slight decrease in urine output, rise in BU and creatine, that makes sense because those, if you aren't getting urine output, you aren't excreting those toxic metabolic buildup. And then because you have transient decrease in blood flow, you're going to have a declining GFR. So how are we maintaining this person? We just need maintenance, sustained decrease in urine output. They will have salt and water overload, which makes sense if you're not peeing everything out, if you're not getting good reabsorption and filtration in the nephron, you're going to have salt and water overload, rising BU, and of course, because you're not filtering it out, hypercalcemia, all of those bad things. Yeah, that just keeps going. So diagnosis, they're going to be hypotensive, low urine output, we talked about that. They're going to be uremic. Serology, of course, we talked about elevated serum creatinine and BUN. You can get metabolic acidosis. Why? Because the kidneys will excrete hydrogen ions. And so if you're not getting the hydrogen ions out, they're staying in your body. So you have metabolic acidosis. You're also not getting out the potassium phosphate, and then you can have anemia because of decreased erythropoietin. Again, I told you that muddy brown casts are the hallmark of tubular injury. So that's why you're getting that, because you know you have tubular injury, the cells are sloughing off into the lumen, then you're getting it out. Okay, so tubulointerstitial nephritis. So this is just inflammation of the tubular cells. It's not the ischemia. It's not the death of the cells. This is just inflammation. So this is a group of diseases involving inflammation tubules in interstitium. Wow. You'll see azotemia. So this is just buildup of the urea products as seen as an increased BUN, blood urea nitrogen, because they're not working from drugs or pylo. I spelled that wrong. Okay, so okay, drug-induced nephritis, you're going to see fever, eosinophilia, that's big here. And of course, if you're seeing eosinophilia, you probably have IgG mediated, so hematuria, mild proteinuria, leukocyturia, and then of course, rising serum creatinine, which is indicative of acute kidney injury, of renal cause or acute kidney injury with oliguria, so decreased urine output. Okay, so I actually put in a slide from our term 5 lecture because I liked how it organized this better than your slide. So I pulled the Facilitators stuff from your last lecture into this lecture because I liked how it explained it. So Brady already talked about UTIs, pylo and everything. So we're gonna go through it one more time. So you can have colonization, bacterial colonization of the periurethral area. You know, it's not a clean area. You know, risk factors are sex, And catheters, urinary catheters are one. Females are more prone because of a shorter urethra. So you just get colonization, and then you can get ascension up to the bladder. That's where you get to cystitis, because you're getting that UTI at that point. If it's left untreated, if it's complicated, it can still ascend up to the kidneys, and that's when you get pyelo and acute pyelo versus chronic pyelo. We'll talk about that, but if you keep going up this ladder, you can get to tubulointerstitial nephritis, and then you can get to AKI, acute kidney injury. So I liked how it organized it. It's kind of like a pathway to acute kidney injury versus just kind of putting things in there. So I just put that slide there, and I reorganized it. So acute cystitis, this is just a UTI essentially. So suprapubic plain, dysuria, frequency, urgency. We talked about the risk factors. We talked about the causes when Brady went over the micro, and then labs. UTI, I'm pretty sure all of them are going to have positive leukocyte esterase, and then nitrites, you're going to have the gram-negative organisms. They use E. coli a lot. They use E. coli a lot with that. And then I already talked about how you can get further ascension and get acute pyelo, so suppurative inflammation of the kidneys. This is an infection, so the inflammation is suppurative. So you can get suppurative inflammation, suppurative necrosis of the area. You will get neutrophil aggregates. So this is a person coming in onset a severe costovertebral angle tenderness. They'll come in and you can barely even tap on their back. It's like they're in immense pain. And then fever, nausea, vomiting, and fatigue, those are all systemic signs of infection. So you're going to have that as well. And then they might have had a history of UTI. But on this slide, I forgot to point out, you can get hematologenous spread from other places. So if you have like an infective endocarditis, and you get an embolization, it can seed in this area and you can get an acute pyelo. So we already talked about this. This is very, very, very important. You can get a papillary necrosis. Remember, this is a suppurative necrosis. So you can get a papillary necrosis where you have necrotic renal papillae. So this is seen as gross hematuria. Risk factor for this complication is diabetes. And then other ones, you can have pyonephrosis, which is just buildup. And so since this is an infection, you're going to get an infected buildup, suppurative exudate. You can also get a perinephric abscess if the infection breaks through and goes into breaks through the renal capsule and goes to the perinephric tissue. And you can also get chronic pyelo. I put this in here because I had a couple questions about this because it was put in here that I don't know what this means. So if you're trying to diagnose papillary necrosis, this would be a differential diagnosis. It's not saying it's under the umbrella of papillary necrosis. It's saying that this is something that you could consider if a patient comes in and they have symptoms suggestive of papillary necrosis. So just understand that analgesic nephropathy is a thing, know what it's associated with, and you're good. But chronic pyelo, now you're involving the renal calyces and the renal pelvis. And so this is getting more serious. This is recurrent or persistent infections. So you're having chronic obstructive pyelo, recurrent infections, superimposed infections. But features your gradual onset of renal sufficiency, loss of tubular function. You can develop hypertension, and then you can develop the focal segmental glomerulosclerosis. And then obstructive uropathy, hydronephrosis, essentially anything that can cause an obstruction can lead to this hydronephrosis as fluid build up in the ureter. Which can then lead to renal atrophy, progressive atrophy, because you're getting dilation. So past the obstruction, you're getting the dilation because it's filled with fluid, and so they're getting progressive atrophy because at that point you then have like a non-functional kidney. So it can be unilateral, complete, or partial. Can also have bilateral. If you catch it, renal function can be relieved. And then renal stones. So this is also a very classic presentation, severe pain radiating to the groin. Why is it radiating to the groin? Well, because the nerve fibers are kind of along the same path. Nausea, vomiting. Nausea, vomiting is because of the pain, because the pain can be so bad. Like they say that kidney stones are worse than a woman giving birth. The pain is worse. And so nausea and vomiting simply because of the pain. And then you can have gross hematuria. That's just simple irritation of the area. If you have a large enough stone, you can actually just disrupt the tissue and get gross hematuria. And because you have an obstruction, you have like this foreign thing sitting there, you can get an obstruction, you can get a superimposed UTI due to the stasis of the urine, you can get hydronephrosis. Remember, if you have an obstruction, past that obstruction, you're going to get dilation of the area. And then it can be associated with gout, cystinuria, and hyperoxaluria. Why? Because this you're increasing concentrations of certain things. And so do know the different types of stones and what can precipitate them, because they might ask it. Okay, so remember how we talked about hypertension back in the cardio stuff? It's essentially the same thing here, benign versus malignant hypertension. So you can get nephrosclerosis. So essentially this is just the effects of hypertension at the level of the nephron. So hardening of the renal arteries and small arteries. So benign, you're gonna have the hyaline deposition. So vascular, you're gonna have the medial intimal thickening hyaline arteriosclerosis. You can have global sclerosis at the glomeruli, and then focal segmental glomerulosclerosis. Of course, this is compensatory. And then at the tubular level, you can have atrophy and then ischemia. And then malignant, remember this is a rapid rise in blood pressure. What makes it malignant? End organ damage. Fibrinoid necrosis of the afferent arteriole, you're going to get that onion skin lesion. Remember, histo is your friend here. And then I put this, the other symptoms in that can clue you in on, oh, this is malignant hypertension. This is what we're seeing right now. And then renal artery stenosis. If you have unilateral renal artery stenosis, this can account for a small number of hypertension cases due to the increase in the RAS system, because you have an ischemic kidney. So then you get hypertension. And then, so renal artery stenosis is most common cause is atherosclerosis. Again, that causes a lot of bad stuff. And then another cause you want to make mention of is fibromuscular dysplasia. And then I just included this. Arteries in the ischemic kidney are usually protected from the high pressure because, you're going to shift it at that point. So now you're kind of protected from the sharing stress versus the contralateral kidney that doesn't have the sclerosis. You're getting more of the stress because you're taking more of the insults. Thrombotic microangiopathies, they just briefly go through this, but again, just lesions in different systems. This is, and it can have renal failure as one of its characteristics. So again, these are systemic things that just have a renal presentation. One that they love to focus on, and I'm pretty, I don't remember which module it is, but one module, they go into every single type of E. coli into great detail. So this is just like a morsel of what you're going to get in the future. But sugar toxin mediated hemolytic uremic syndrome. Look for a kid that just recovered from a bout of bloody diarrhea. Why did the kid have bloody diarrhea? This E. coli is 0157H7. That is what is going to cause the bloody diarrhea. Then they can get this hemolytic uremic syndrome. So So a kid that comes in, had bloody diarrhea, now has renal symptoms. What was the causative agent? Something like that. You will see schistocytes on the peripheral blood smear, a purpuric rash. The kid can have a headache, confusion, seizure, stroke, fever. And then another one that they throw in there, thrombotic thrombocytopenia, purpura, associated with lupus, HIV, hematologic malignancy. Okay, then cystic diseases, they have a few slides on this. I put in what I remember being like the big stuff. So ADPKD, so this is a, autosomal dominant polycystic kidney disease. This is in adults. So this is associated with the polycystin proteins. It's autosomal dominant, which means all generations are going to have it, unfortunately, and it's going to manifest in adulthood, not in the kids. There are two types, PKD1, if you have the if it's with the PKD1 gene, it's going to be more severe, it's going to present earlier, and then it's going to progress to end-stage renal disease. Something you can also have if you have, if it's the PKD1 gene, or pancreatic and liver cysts. And then PKD2 gene, this is a slower progression, it's more mild, and it's going to present later in life. So what are you going to see? This person is going to come in with hematuria, and will have hypertension, flank and back pain. I think when one of the videos I watched, they're like, commonly it's someone gets hit in the back and one of the cysts ruptures and you have gross hematuria. So they're going to come in, they got hit and now they're peeing blood, and then they can find this. Some things that are also associated, you can have a mitral valve prolapse, you can have a Berry aneurysm, and then you can also have clonic diverticuli. And then in the kids, it's autosomal recessive for the fibrocystin proteins, and then it's the PKHD1 gene. Alport syndrome, can't see, can't pee, can't hear a bee, straight from first aid, but they're going to come in with it's a mutation in the type 4 collagen. So you're getting irregular thinning, thickening, splitting of glomerular basement membrane, which causes a basket weave appearance on electron microscope. And then the gene is the COL4A4. So the patient's going to come in with hematuria. They're going to have sensorineural deafness. Yeah, so look for those two things. So renal, eye, ear. That's Alport syndrome. And then I'm going to quickly go through these. There are a couple things that they like to associate with the renal tumors, and I'm just going to tell you what those are. This is just the introduction. So an angiomyolipoma, that's benign. It's like a fat tumor. Renal cell carcinoma. This is malignant. The biggest risk factor is smoking, also obesity, hypertension. Highlight polygonal clear cells. If they talk about polygonal clear cells, you can assume that you are talking about renal cell carcinoma. Also highlight star, it can invade the IVC. So you get hematogenous spread to the lungs and bone. That's very big. So it can invade the renal vein, and if it grows within the renal vein, it can extend up to the IVC. And this is how you're getting the hematogenous spread of this cancer. Highlight that. So what is the patient going to have? Hematuria, you can have palpable mass, flank pain, fever, weight loss. You know, all of those are pretty non-specific. Hematuria, you know, is kind of kidney. And so palpable masses might be able to clue you in, but the clinical the symptoms aren't necessarily what's going to clue you in. What's going to more clue you in on is the histo, you know, the polygonal clear cells, if they put this slide on there. Another thing that I don't know if they've introduced it to you before this point, paraneoplastic syndromes. So oftentimes it's hard to diagnose something because the actual cause is mimicking something else. So for example, this is so big in respiratory. So when you get to the lung cancers, oh my goodness, there are so many paraneoplastic syndromes, like it's crazy. But essentially you're presenting as one thing and it's kind of masking what it actually is. So even though it's something wrong with your kidney, it's acting like it's a different thing. So abnormal hormone production. So It uses Cushing syndrome as an example. So all of these different things, they have nothing really to do with this, the renal cell carcinoma, but the paraneoplastic syndrome, it's kind of acting like it's something else. So you could be worked up for something that has nothing to do with what the actual cause is. So that's paraneoplastic syndrome. I'm pretty sure this is one of the first times they introduce it to you, but it becomes really big later. Wilms tumor, this is in kids, WT1 gene on chromosome 11p, large, well-circumscribed mass. Anaplasia correlates with presence of TP53, and then prognostic factors, anaplasia. I'm pretty sure you guys talked a lot about that in FDCM. Anaplasia is pretty much loss of differentiation, which is very bad when you're talking about cancers. So make that association. And then congenital anomalies, I put this on here because I don't remember this being a huge thing. I remember references of vesicouretic reflex in other places, but not on its own. And then bladder tumors, the biggest thing are the risk of smoking, and then this cystomiasis or whatever. So cystosoma, I don't know how to say that, but those are the two biggest risk factors for bladder cancer, associated with squamous cell carcinoma. But that is it, guys.
All right. If y'all were like me, the diuretics kind of made sense, so we'll go through those quickly. I think what I had the most trouble with was their antiarrhythmics. Now, in term 5, we actually went through all of the arrhythmias and looked at them with EKGs. So why they teach you the antiarrhythmic drugs in term 4 and you actually learn the arrhythmias in term 5, I don't know. But when we get to the antiarrhythmics, I will tell you what you need to know for the questions that they're going to ask. Because I went into the exam being like, if they tell me it's like atrial fibrillation, I don't know what drug to give. But that's not how they tested. They tested on saying like, which one prolongs QT, and like you want to give one that is good for extending QRS. So that's what we'll look at there. But quickly we could run through the diuretics. So remember, diuretics, good for the heart, good for your vessels. You got to get the fluid off. Good for the renal system as well. So that's why cardio and renal are together, because they kind of work in conjunction with the whole volume regulation. Okay, so typically when we talk about either heart failure or renal problems or hypertension, the first line drug you want to give is a diuretic. All right, so let's get to the actual drugs. Now, loop diuretics are super strong. Okay, so they're not first line, but if a patient comes in a congestive heart failure, like full blown like left heart failure, has dyspnea because there's fluid in the lungs, has right heart failure because of that, and now has peripheral edema, you just give them a loop diuretic. You give them furosemide, that's Lasix. You give it to them right away because you need to get all the fluid off. But when you're talking about just regulating high blood pressure, you don't give a loop diuretic first. They'll bottom out, right? They'll get orthostatic hypotension. It's not a first line for that. But when you think about heart failure and all of the peripheral edema, you definitely want to give it. So when you think of loop diuretics, think of it being really strong, okay? So management for edema. Just a good thing to know, they are used on these channels here, the sodium chloride potassium channel, this co-transporter. Okay, and they obviously work in the loop of Henle. Super important to know these. My highlighting by now probably red is super important, green's a little less important, and yellow's a little less. So some of these are going to be more important than others. And a good thing that they actually increase renal blood flow down the line. You learn about that in term 5. So let's see. Obviously, these adverse effects are going to be super important too. Ototoxicity, okay, it changes the fluid balance in the ear canal. So ototoxicity is a big one. And then some of these other ones, you definitely want to remember these. Hypokalemia versus some of the diuretics that work downstream are going to be potassium sparing, okay? And watch out for the allergic reactions with sulfa drugs. Okay, so good little explanation here. All right, so thiazides, they're great first line drugs. HCTZ is typically the one they use, hydrochlorothiazide, works down in the distal tubule. The big question they always ask, it probably should be in red here. It causes it causes hypercalcemia, all right? So if you take a thiazide and then you check your blood, you'll have elevated calcium in your blood. It causes hypercalcemia, which is why it's good for treatment of hypercalciuria. If you have a lot of calcium in your urine and you want to pull it out of your urine and get it out of there, you can give a thiazide. So people that have chronic kidney stones, calcium kidney stones, you can give them a thiazide and it'll get all that calcium off out of their urine back into the blood. But thiazides are very classic, prototypical for something that causes hypercalcemia, okay? So make sure you know that. And just so you know, they work on these sodium chloride cotransporters down in the distal tubule. And I remember that they deal with calcium causing hypercalcemia, because remember PTH works down in the distal tubule too. So that kind of all puts it together for me. All right, so you can see the hypercalcemia. That's pretty much the big one you need to know there. Again, can cause hypokalemia, just like lupus, right? Increased potassium excretion. All right, and that'll be different from the potassium sparing ones. Now, stuff like this, like I did highlight it, but honestly, like if you ask me in the exam if I knew that, I did not. Like, it's one of those things. I don't go back after the test and change my highlighting, but things like that in numbers and stuff sometimes, it's not terribly important. All right, so again, hypercalcemia, if it's not written on your slide, that would be the big one to know. And then, the mnemonic for this is glukes. Let me just put it here for you guys. GLUC, gluk-S. So it causes hyperglycemia, lipidemia, uricemia, hypercalcemia, and hypersensitivity. Okay, so what's important here? Watch this for diabetic patients, okay? It's a good question to ask. Probably don't want to use it, right? Use something else. ACE inhibitors are good, right? They're renal protective for those diabetic patients. Okay, so glukes is the way to remember that one. All right. Now, potassium sparing. The way to remember these is it's SEAL. S-E-A-L, I believe. Yeah, so these first two are aldosterone receptor antagonists. What's very specific about these, they cause anti-androgenic effects. So they can cause like gynecomastia and stuff. Okay, but they're also potassium sparing. If you're not using aldosterone, that sodium potassium exchanger isn't going to work. So you're going to pee out a lot of sodium and you're going to hold on to that potassium. Okay, and then the other one, amiloride, what's the L for? Amiloride, hold on. I'm sorry, it's SEAT, not SEAL, it's SEAT, S-E-A-T, and triamterene is the other one. Okay, hold on, let me go back. All right, so just remember potassium sparing, the ones that work on aldosterone, they have anti-androgenic effects, okay? It's like gynecomastia. And then anytime you're messing with holding on to too much sodium, or too much potassium, you're at risk for arrhythmias. Remember, that's a big problem, either hypokalemia, you have to watch out for arrhythmias. Very important, we'll get to in a little bit. It may not be intuitive, it's not to me, but spironolactone is one of those drugs that is, it helps to prevent cardiac remodeling. Okay, so there are a couple of drugs, somebody could throw it in the chat if they want, but I think we're going to come up to it. A couple of drug classes are prevent cardiac remodeling, which is very important because cardiac remodeling causes systolic and diastolic dysfunction, right? So by definition, these drugs such as ACE inhibitors, beta blockers, spironolactone, I believe maybe calcium channel blockers is the other one, they all prevent cardiac remodeling. So they all technically help with longer lifespan, right? Cardiac remodeling is the definition of heart failure, okay? So these drugs are very important, but it may not be intuitive that spironolactone is one of those, but it is. Okay, so things like digoxin is not, like, even though you think, well, it's helping contract the heart and work better, it's only for for symptomatic relief. Okay, let's see, right? Yeah, anti-androgenic effects. Obviously hypercalcemia, right? Should be able to recognize that in the lab values. And then we have the ones that work on the ENaC channels, amiloride and triamterene. Not super important, but they're there. So again, they are potassium sparing. They're going to prevent that exchange from sodium and potassium. All right. And then carbonic anhydrase, acetazolamide, basically just helps to prevent bicarb. It's to prevent bicarb. You pee out bicarb, right? Is retained in the lumen. Yes. Okay. So it prevents reuptake of bicarbonate, right? So these are when you would want to use that. Mountain sickness makes sense because if you're in respiratory alkalosis from hyperventilating, you can use carbonic anhydrase. You'll pee out a lot of the bicarb and it'll acidify the blood and try to bring you back to baseline. Okay, so that's all you really need to know for that. Right, well, yeah. Yeah, so obviously if you're peeing out a lot of bicarb, you'll end up in metabolic acidosis. And crystal stones, yeah. I don't know how important that is. All right, good. Again, I know I'm going kind of fast. If y'all have anything I want to bring up, just stop me. Osmotic diuresis. This will help. Mannitol helps to bring all the water into the urine. It's an osmotic agent, so it'll bring a lot of fluid in, so you could pee it out. Not really used. They probably want to ask you about that. Okay. ADH. This is not super important either. But ADH, right? Remember, brings free water back into the body. So if you have something like syndrome of inappropriate SIADH, of inappropriate ADH, you can give something like this, right? There you go. And then you have your charts. If you're a chart person, go with that. All right, now anti-hypertensives, you know the staging by now. They could ask you that, but make sure, or pimp you in when you're doing small group with that. But this is what you should go with. Some textbooks or websites will give you differences. This is the standard that SGU uses, okay, for stage 1 and stage 2, or pre-hypertensive. Well, they don't even call it pre-hypertensive anymore. Just stage 1 and stage 2. All right. So again, with we're not going to go through how all this works. I want to just talk about the drugs. Right. So current treatments. All right. So again, if you're in heart failure, you want to decrease. You don't want to be in volume overload. You want to decrease the volume. So first line agents such as ACE inhibitors are going to be very important. You need to know which ones are first line, which ones are second line, and whatnot. Okay. So these all fall together. Remember, you never give an ACE inhibitor and an ARB together. They basically work the same. Okay. So you're going to give one of these two, throw a calcium channel blocker and a thiazide. You'll be good to go. You can also add a beta blocker and something like spironolactone too if you need to. All right. And then ACE inhibitors, you pretty much know how this works now. They're going to help to block aldosterone downstream, or it's going to block angiotensin 2, and angiotensin 2 will activate aldosterone and ADH. So if you use an ACE inhibitor to block angiotensin 2, you can help prevent the reuptake of fluid, and you can help prevent that vasoconstriction from angiotensin 2, right? So it's a twofold effect. Big thing with ACE inhibitors, they increase bradykinin. Bradykinin will cause a dry cough. It'll also cause angioedema. So if that happens, you just switch the If the patient comes in with a dry cough, you switch the patient from an ACE inhibitor to an ARB. No big deal. Okay. You can see, y'all all know now how aldosterone works through this process. All right. Now, super important. It's very good for diabetic patients. ACE inhibitors, pretty much first line for everybody, unless you're in like severe renal failure. But definitely with these diabetic patients, you want to give them an ACE inhibitor. Okay. Now, what actually happens when you give an ACE inhibitor is that it can cause dilation of the efferent arteriole. Okay. So if our glomerular filtration is going to go this way, right? Blood's going this way, and it has two choices. It either goes down or it goes this way, okay? If we dilate this, right, like we're doing here, we're technically gonna decrease our GFR. Okay? So ACE inhibitors will do this. ARBs will too. Because it's blocking this angiotensin 2, so you're not going to get constriction. So you can, now this is fine to a certain point, okay? So if you, for people that don't have renal failure, decreasing your GFR a little bit is not that big of a deal, so you can use an ACE inhibitor. But when a patient gets into, say, stage 5 renal failure and their GFR is like 10%, you need to take them off of this because that 10% is all they have left, okay? But in a general sense, you can use ACE inhibitors unless there is a significant GFR reduction initially. Okay. Patients, right? So yeah, so like and I think Dr. Clunes brought this up a lot. This bilateral renal artery stenosis. If you were to give an ACE inhibitor, it will cause a drastic decrease in GFR. So you need to be aware of that. So not only those patients that have severe renal failure, but with this bilateral renal artery stenosis, adding an ACE inhibitor will decrease the GFR a lot quickly. So you need to be aware of that. So never give an ACE inhibitor if it's bilateral. All right, yeah, you can't give it in pregnancy either. You can get congenital malformations and decreased development, yeah, in urea and renal failure, okay? All right, good. Come on, oh, that's it. All right, so far so good. ARBs, very similarly, they just don't activate bradykinin, so you won't get that call for the angioedema. And they end in sartan. All right, so same mechanism pretty much. Don't give them in pregnancy, same principle as ACE inhibitors. And again, with that bilateral renal artery stenosis, it is the drug of choice for unilateral. So make sure they're talking about bilateral. Too much decrease in GFR too quickly, not good. All right, and then renin inhibitor, you think they like this drug, that I don't know what the pharmacokinetics of it, but they don't use it that much. I just remember it's a renin inhibitor because it ends in ren. Okay, but I doubt they'll ask you about this one. Okay, so then we get to our calcium channel blockers. Now, there are two classes. They're the non-dihydropyridines and the dihydropyridines. It is important to note the differences here. Dihydropyridines basically only work on the vasculature, okay? They're gonna work to vasodilate the vasculature. The non-dihydropyridines work on the cardiac myocytes and the vasculature, okay? So typically, if a patient just has benign hypertension and no heart failure, you just give them one of these and you just dilate their vessels. But if a patient does have some sort of heart failure and hypertension, you give them the non-dihydropyridines. I always got these confused. It was a pain. So I just remember DNA. So DNA, right? DNA, those go together. And those are just for the vasculature. That's what we're talking about here. The other ones go with the other set. All right. Good. So you know that they also fall in that class class 4 of the antiarrhythmics, or calcium too, right? So those are when you're going to use those non-dihydropyridines. All right. Kind of just goes into the process, but it's a sodium calcium exchanger. So you're blocking calcium from being available to the myocytes. All right, so again, first line drug. And just take note, you would not give these dihydropyridines for cardiac arrhythmias. If you think about it, these are just working on the vessels. So if you vasodilate the vessels, you can get reflex tachycardia. It may precipitate some sort of arrhythmia. So just be careful with that. You'd want to give one of the non-dihydropyridines because it's actually working on those cardiac myocytes too. Yeah, here you go, that reflex cardiac stimulation. Big one, I put it in red. They like to test on that. Verapamil will cause constipation. Gingival hyperplasia as well. Now, the non-dihydropyridines, these are the ones that would fall in that class 4 that you'd want to give for certain arrhythmias. And then we're not going to talk about the diuretics again, but yeah, so again, the glutes is what you can use for that, for these thiazide adverse effects. Loops, we talked about those, potassium sparing. Was there a specific slide that said which ones are prevent myocardial remodeling? Maybe not. And then beta blockers, of course, these are basically just going to help to slow down. It's more of a beta 1 effect. You're slowing the heart rate down because if you think beta 2, well, you're preventing that vasodilation. You think of these as more of the beta 1 effect that they use, right? So you're thinking of like atenolol and metoprolol. Remember A through M, the ones that fall A through M are selective. So they'll choose like beta 1 over beta 2 and N through Z, beta 1 equals beta 2, okay? So it's a little tricky. Why would you want to block beta 2 since it does vasodilation? But this is mostly, think about the beta 1. You're putting some relief on the heart from working so hard. Okay, and you can see this here. All right, the thing that they like to talk about with beta blockers is that in diabetic patients, when they have episodes of hypoglycemia, a lot of times the first symptom of that is tachycardia, okay? So if a patient's on a beta blocker, a diabetic patient is on a beta blocker, they need to be aware that they might not get that initial warning sign of tachycardia because the beta blocker is in essence slowing down the heart rate, okay? So that's a good test question. Obviously, you're not giving a beta blocker to someone who has asthma. All right, so alpha-1 blockers, remember alpha-1 works on those vessels to vasoconstrict. If you block those, you can vasodilate, right? So that's good. Also, they use it for BPH as well. Okay, so yeah, you're blocking that sympathetic response so you can, the patient can urinate better. All right, and then mixed alpha beta. Yeah, these are more common these days because you could get you can block that alpha-1 and you could also block the beta-1 of the heart. So you get vasodilation and you get a decreased heart rate. Clonidine is a tricky one because alpha-2 is more of an inhibitory, it's centrally acting. So it has this like autonomic effect of inhibiting the autonomic system. So it like slows down your sympathetics. They use that sometimes. The thing you have to watch out for this is if patients get off of this too quickly, they get what's called rebound hypertension. So their blood pressure skyrockets. Okay, so if you ever see rebound hypertension, they're talking about clonidine. It's classic for that. Here you go. Methyl-dopa, good for pregnancy. That's the drug of choice there, so keep that in mind. And then you have your direct vasodilators, okay? So hydralazine and minoxidil, which is Rogaine actually, causes hypertrichosis. They don't use it first line, but it works directly on the smooth muscles to dilate the vessels, okay? On the arterioles, direct vasodilators. All right, Watch out for that lupus-like syndrome. They'll just give you symptoms of lupus. They won't tell you it's lupus-like syndrome. So you need to know the drugs that go with that. And if there's any sort of malignant hypertension that you need to address immediately, minoxidil can work. But typically they talk about hydralazine. All right. Pulmonary hypertension. Remember, anytime you have pulmonary hypertension, it can lead to cor pulmonale, which means right heart failure. So you don't want that to occur. So prostaglandins are always going to help to vasodilate. So that's a good way of doing it. Endothelin is a vasoconstrictor. So if you inhibit that, you could be good. Sildenafil is Viagra, but it is a vasodilator. So it can be used in pulmonary hypertension. Okay. And you can see it is important that you know which they go with which. So ipoprostol is PGI2. I think that's really the only one you need to know. Bencentin, I don't know if they'd ask you about that. And they just like this one, the class that it works, right? So it's inhibitor of phosphodiesterase 5, increases cGMP, increases nitric oxide. So it'll improve blood flow, as Viagra or in the pulmonary system. Can't give it to a patient on nitric oxide. A lot of patients take nitro for angina. They take those sublingual tablets, nitroglycerin, and it'll help to vasodilate the coronary vessels, right? But so you can't give them something like this because that's too much nitric oxide. They'll vasodilate too much. They'll go into shock. All right, so definitely know these. These are very important, what comes with what, first lines versus second lines and stuff like that. And just knowing importantly, like diabetes, definitely get them on an ACE inhibitor that's renal protective, stuff like that. All right, good. All right, then we get into the hypertensive crisis. So again, nitroprusside is a good one that you can use. That's typically what they use. This is the emergency situation. So you need to get prompt vasodilation. These patients coming in, their systolic pressures over like 200. Okay, it inhibits, I think, complex 4 of the electron transport chain. So it causes cyanide toxicity. You can give sodium thiosulfate to treat that. Yeah, not that that's high yield, that you'll get to that later. We talked about labetalol. I'm pretty sure labetalol is good for pregnancy as well. It doesn't say that here, but I'm pretty sure that's right. Vindolapam, whenever you think of a dopamine receptor agonist, think that it's good for the kidneys, okay? Typically, the only thing I've ever seen when they use something like this is when they're worried about the kidneys, such as renal insufficiency, okay? Because they have dopamine receptors, I believe, in the afferent arteriole that help to vasodilate, so you get increased blood flow to the kidneys. So that's good to know. Yeah, calcium channel blocker, of course, nitroglycerin. Yeah, but typically they would give nitroprusside. All right. Yeah, and then these are just, you can go through these on your own. Hydralazine is good for pregnancy as well. So anytime a patient gets eclampsia or preeclampsia, that causes hypertension, you can give them hydralazine. All right, heart failure. Now, we talked about this, what the difference is, systolic versus diastolic. So systolic, you should say pump failure. If you're giving drugs to help with pump failure, you're gonna give something that's gonna help the pump work better. Remember, diastolic is talking about filling problems. So if you're giving something to help with the filling problem, you're giving something to help relax the heart. Now, there are some crossovers here that you want to give just in heart failure in general, but some of the specific ones, such as digoxin, right? You give it for systolic because it helps the heart pump better. Whereas for diastolic, you can give like a calcium channel blocker. It'll help relax the heart and help it fill better. Okay, so keep those in mind. If you think about it, think through it, you really don't have to memorize it. It'll just make sense. Okay. Yeah. Okay. Right. So reduced ejection fraction. We're talking about an ejection problem. Okay. So It's dilated, it's floppy, and there's an ejection problem at this point. So spironolactone, direct vasodilators, those can be used, inotropic agents such as digoxin. Whereas diuretics, the ones in yellow, you can use for either reduced or preserved. Okay, so ACE inhibitors, diuretics, beta blockers, give them for all. I think spironolactone may as well be for both, but direct vasodilators and inotropic agents you want to give for reduced because it'll help the blood flow, help the pump work better. Okay, so don't listen to me. Spironolactone apparently is only used in reduced ejection fraction. Okay, that's why it's in green. But if it's preserved, I guess you don't want to use that. Again, so preserved, we're saying that it's a diastolic problem. We want to be able to relax the heart a little bit more so that we can get more blood into it, right? So again, you could use diuretics, ACEs, beta blockers, and the one that you would want to use in preserved ejection fraction is calcium channel blockers, because again, that calcium blockade will help to relax the heart a little bit more. It'll help to feel better. All right, good classes, that's fine. Yeah, so here's the example of prolonging survival. They help to prevent myocardial remodeling. So by definition, you're helping with survival. Of course, they are teratogenic, so be careful with that. Same thing with the ARBs, direct vasodilators, talked about those. Here's one of those things that comes up sometimes. For whatever reason, ACE inhibitors don't work as well in African-American populations. So you can switch them. Instead of using the ACE inhibitor, you can use a direct vasodilator. Okay, just in case they ask you that on the exam. I don't know how clinically, if doctors even go through that process, but I think there were some exam questions that talked about that. Okay, again, remember direct vasodilators work on with nitric oxide. You got to watch out if the patient is on sildenafil. And then again, hydralazine, that lupus-like syndrome that comes up. All right, beta blockers, reverse cardiac remodeling, help with long-term survival. Okay, now this should make sense. If the heart can't properly compensate, right? If it can't compensate for the heart failure. So say the left heart's failing and the right heart has to get more blood to if it can't properly do that to keep the stroke volume up, you don't want to give a beta blocker, because the beta blocker is going to stop or decrease the blood flow. It's going to decrease the work of the heart. It's going to decrease contraction. So if you're decompensated, your heart's working just to keep you alive. So giving a beta blocker is not exactly a good idea. Okay, and we talked about spironolactone. Yeah, with those, remember they have those anti-androgenic effects. Hypercalcemia, watch out for arrhythmias. Okay, now digoxin's the big one. Again, they really don't use it that much anymore, but when it first came out, it was like this novel drug, you know, it like makes the heart just work better. Remember, it has this inotropic agent. It's a negative chronotrope, which means it slows down the heart rate, but it's a positive inotrope, which makes it squeezes better, right? It contracts harder, and it works. Yeah, you see that here. Right, and yeah, so by doing that, working together to have more of a less heart contraction, but when it does contract, it contracts stronger. That process will help to decrease myocardial oxygen demand, okay? And this is how it works. Basically, it blocks the sodium-potassium ATPase. So sodium will be inside the cell. This is tricky. This is bidirectional, these little arrows. So what happens is, by blocking this, there's a ton of sodium in the cell. So the sodium over here wants to rush out of the cell. So it rushes out. That means calcium comes into the cell. So there's a lot of free calcium, okay? They could ask you about this process. So just remember, this goes both ways. So if you have a lot of sodium in, you kick the sodium out to bring calcium in. The more calcium you have, the stronger you can contract the heart, okay? Yeah, so atrial fibrillation. So the atria is just kind of shaken, right? You need to be able to say, slow down. Let's have a nice concentric heartbeat, right? So atrial fibrillation is a good example where digoxin could be used. But again, digoxin is for symptomatic relief. It's not going to help with cardiac remodeling or anything like that. And this is why it's really not used as much anymore, because of this toxicity, okay? That it could have. One of the ones that they talk about classically is this yellow hue in your vision. So be aware of that. Anytime they talk about that or halos and dark objects, that could be digoxin toxicity. Now, these precipitating factors, what this means is if any of this is happening, when you give digoxin, it could lead to digoxin toxicity, okay? So if a patient has hypokalemia, that will block this pump, which means there'll be more sodium available to help to shuttle the calcium. So it can cause too much calcium intracellularly. But just in case these come up, it's a little complicated, but just be aware of these. These can lead to, if the patient is in a setting of this and they take digoxin, it could cause digoxin toxicity. Okay, and these are the interactions. So whereas if you have hypercalcemia, it could lead to digoxin toxicity, or hypomagnesemia, they work opposite. Okay, so just in case they ask that, I don't know if y'all have come across questions like that. That is a little bit complicated, like I said, but those are some of the things. But the main one to remember is a setting of, you never want to give digoxin in the setting of hypokalemia, okay? Because that'll make it worse. All right, then the adverse effects as well. Okay. Right, and so you never want to give it for a diastolic dysfunction. You always give it for systolic, because it will help with contraction. All right. Treatment for diet, okay, we kind of talked about this. Here are some other inotropic agents. Go through these on your own. I mean, these weren't super important. CAMP, phosphodiesterase inhibitors, yeah, okay. I don't know that they'll ask about that. Remember when we talked about dopamine, we're talking about help with renal perfusion. Dobutamine, they only give this when the patient comes in and they're in complete heart failure, and it'll help to stimulate the heart, stimulate contraction. Glucagon can be used, increase CAMP, so similarly to like beta agonists as well, right? Works through a similar process. All right, now, again, like I said earlier, these antiarrhythmics are difficult, but the test questions weren't as bad as I thought. Like they only tested us basically on what I'm going to explain to you guys here. So there are two different electrical impulse graphs that we're going to look at. This is the myocardial, the one you know classically, right? So we have that upstroke of sodium, then the potassium, then that calcium plateau, and then potassium, and then sodium, right? So the class 1 and class 3 are going to work on this graph, okay? Class 2 and class 4 are going to work on the actual nodes, the SA node specifically, okay? So when we look at these, I mean, we've talked about this in FTM and stuff. I want to get to the drugs. So as I said, you can see the two different graphs. Remember, 1 and 3, the sodium and potassium antiarrhythmics are going to work on this. And then 2 and 4, the beta blockers and calcium channel blockers are going to work on this, okay, the pacemaker graph. So it's very, very different and very important that you know the differences there. Okay, let's get to the drugs. So again, they briefly talk about these different arrhythmias, but we really get into it in term 5. You really don't need to know how these work right now. You just need to know the definition of how these these drugs work. Okay, so the class 1, remember, so it's sodium, so we're gonna work on the myocardium. Okay, so 1A, B, and yeah, let's get to those. Okay, so the sodium. So we're working on the myocardial graph. Did they not show it again? Okay, here we go. Yeah, so you want to slow the rate of the phase 0 depolarization, and what you could do is you could see that here. So on a test question, they could ask you, they could say the patient has an arrhythmia. They want to use a drug that will not only extend QRS, but it'll also extend QT. Okay, so you would know the definition. That would be a good example of a class 1 antiarrhythmic. They may even give you this graph. Okay, we had graphs like this. So make sure you're able to identify this graph and know which one goes with which. Okay. Right, and there are some weird little side effects, like quinidine has this synchronism, blurry vision, tinnitus, and headache, even psychosis. So be aware with that. Another good thing that you could know now, anything that increases QT, okay, can lead to torsades de points. Now, why is that? If you extend, let's go back to the picture. If you extend this QT right here, what you're doing, like the longer, so by extending QT here, you're making this, technically you're making this whole interval longer. I mean, you're extending it here, but what happens in this zone is very dangerous. You're tempting fate here, because what can actually happen is you can get re-entrance, you can get abnormal polarizations here. And the problem is the longer you prolong that QT, the more opportunity they have for an aberrant impulse to go through. Okay, so just keep in mind, anytime you prolong that QT, you can be at risk for getting torsades de points, which means it starts firing straight through. And so it's big for the class 3 drugs, but it can happen in these as well. Okay. Canamide's another one. Again, lupus-like syndrome. Good to know that. This is the other one, dysopyramine. I don't know that they asked us anything about that. Just know which drugs go with which class. Okay, good. Let's see. Okay, so now they could ask you, we want to use a drug that prolongs QRS but shortens QT. That's classic for these 1B antiarrhythmics, such as lidocaine, okay? So again, you have to be a cardiologist looking at arrhythmias to decide, do we want to shorten the QT or prolong the QT or whatever? So you don't really need to be able to differentiate types of arrhythmias with the drug. You want to just be able to identify what goes with what by definition. All right, but a caveat, it is good to know that lidocaine can be used for ventricular arrhythmias. Okay, so just know that too. It comes up in term 5 as well, but just keep that in mind. Okay, so then we have our class 1C. Now look at this. What if they said we want a drug that will prolong the QRS significantly but not change the QT? Well, then you could use the 1C drugs. Okay. So again, ventricular arrhythmias, but again, this could be used for either. So, you know, take that as a grain of salt. This is a great example of something they could ask on the exam. I would put a star on this slide. So make sure you can differentiate these different graphs, which one's 1A, which one's 1B, and which one's 1C. All right, definitely high yield. Okay, phase 0 and 3, phase 0 and 4, and just phase 0 here. Okay. All right, and then our beta blockers. Now, we said this class 2, these beta blockers are going to work on the node. Okay, so we're looking at that nodal graph now, the SA node. So what they do by definition, they decrease the slope of this phase 4. Those initial phase 4 sodium funny channels, if you decrease the slope, it's going to fire less frequently. okay? So you're gonna get a prolonged or increased PR interval, okay? And that'll help to slow down those SA nodes the SA node firing. All right, and then it just kind of goes into, the side effects of these beta blockers. All right, now, potassium channel blockers, class 3, we're going back to the myocardial graph, okay? Now, look at this, look what they do. They prolong this QT, that is what they do. They work on this repolarization phase, this phase 3 potassium channels. So what do you think is a big problem here? Torsades points, right? Or having these new arrhythmias that form. Okay, so you have to be aware of that. Amiodarone is very tricky. I'm not sure that they use it so much just because it has so many side effects. Okay, so you can see here, like, it could be used in the atrial arrhythmias or ventricular arrhythmias. So it's not going to be important that you can differentiate what arrhythmia to use this with. You just want to be able to classify it, okay? So it's by definition going to prolong this QT phase. It's going to work on phase 3, this repolarization phase, by blocking the potassium channels. All right, and then here are some of the side effects here. Pulmonary fibrosis, that's a problem, right? It could cause hyper or hypothyroidism, get photosensitivity. Another thing, a big buzzword, blue skin discoloration. And then again, of course, it could cause torsades de points. All right, sotalol falls into the same category here as that class 3, and dofetilide too. Okay, atrial, let's use it primarily for atrial issues. All right, then class 4, now we're jumping back to the nodal graph, okay? So these calcium channel blockers, similarly to the beta blockers, will increase your PR interval. So we're slowing down the heart rate. Now, these will work on the calcium aspect. Remember this phase 4, and then this is phase 3. Excuse me, wait. Sorry, this is phase 4. This upstroke is the calcium phase, which is phase 0. So it's going to slow the rise of this portion of the action potential. Remember, the beta blockers worked on 4 over here, which was this sodium funny portion. Sodium funny portion. The sodium funny channels. The beta blockers work down here on this portion, phase 4. They slowed the slope. They decreased the slope. Okay, that was the beta blockers. And now we're looking at this. This is called phase 0. This is the calcium phase. So if they slow this rise, these class 4s, then it'll help to increase your PR interval, so it can help to prevent tachycardia or arrhythmias. Okay, remember, we're using those non-dihydropyridines because they work on the heart as well as the vessels. Okay. And then you can see the atrial supraventriculars. Again, don't forget verapamil causes constipation. And then digoxin, we talked about that, positive inotrope, right? Negative chronotrope. Typically, okay. Yeah, so they'll use it to control ventricular rate if they did use digoxin. So aflutter or fibrillation. But again, like I said, y'all really, if y'all just know the definitions, what does what and works on what phase of those graphs, you're golden. Adenosine, yeah, very short acting, can help to fix arrhythmia short term. Right. So abolishing acute supraventricular tachycardia. So you can give adenosine, and it'll help to fix it in an acute setting. And I don't think they'll ask you about any of this, magnesium, atropine, anything like that. All right, what's left? I think they just go over, okay. They kind and like, just know, okay, this should make sense that the ones that work on those nodal graphs are beta blockers and calcium channel blockers, right? Those were the graphs. The ones that worked on the muscle were the sodium and potassium. So 2 and 4, beta and calcium, work on the nodes. 1 and 3, sodium and potassium, work on the myocytes, okay? Other than that, like diving into this too much, just not, you don't really need to. All right. Yeah. So it should make sense. If you want to slow the rate down, you can give these beta blockers, calcium channel blockers. That should make sense. And then rhythm control can be done with these. Again, this is a little bit more than you really need to get into. All right. So anytime you have an angina, you can give nitrates. That's pretty much first line. It will help to vasodilate, help with that chest pain. Beta blockers will slow down the heart. Calcium channel blockers help to relax the heart. Ranolazine, it almost works opposite of digoxin in that it prevents intracellular calcium. Okay, so if you don't have intracellular calcium, the heart won't work as hard. It won't have as strong of contractions. All right, but you know how these work. Nitrates, nitric oxide goes through the cGMP pathway, guanylyl cyclase. All right, and much of the same here. Right, so if you keep in mind that in the beginning of the lectures, this lecture, which ones to use with angina, you want to slow down the work of the heart, oxygen demand, and you want to vasodilate. So think about that, and that'll help with the angina. First line is typically nitro. All right. All right, coagulation. This is a great, I don't know that I'm even going to go through this. I think Dr. Dasso does a really good job explaining everything here with these. Know just what classes go with what, and you know what the major side effects are, right? But I think Dr. Dasso's test questions are very similar to his IMCQ questions. So just know what goes with what. Particularly know about heparin and warfarin, right? Remember, warfarin takes a little while to kick in, a couple of weeks, so you always give heparin first as you transition to warfarin. Know like heparin-induced thrombocytopenia, that's a big problem with heparin, and know that the side effects of warfarin too, in regards to like vitamin K. If you have too much warfarin, you can give vitamin K to help to alleviate it. All right, and then the hyperlipidemics, I mean, knowing, oh gosh, yeah. There were like hand signs for this, right? I forget them. Like 1 is chylomicron, 2 is LDL, something like that. I'm sure somebody has the picture. I might have used it in one of our old reviews. All right, so first line statin always, unless there's a reason not to give it. But knowing which ones directly do what, like statins, the big thing about statins is they decrease LDL. Like some of the other ones, I don't remember off the top of my head, but like fibrates will decrease triglycerides. Like that's a big thing. So knowing what their major effect is will be important. Niacin, remember that'll cause flushing. You can give aspirin prophylactically for that, but knowing stuff like hepatotoxicity and hyperglycemia as well, knowing that, yeah, LDL, yeah, there should be a table somewhere that has everything. Honestly, I might get 2 or 3 questions on this, so. Yeah, but yeah, so like, see what I have highlighted here? Statins work primarily on LDL. Fibrates are gonna work mostly on triglycerides. Niacin is gonna help with increasing your HDL and decreasing your triglycerides, okay? So these are kind of things that are important to know. Yeah, and here you go. So this would be what would be good. If in doubt, just give a statin, except they're contraindicated in pregnancy.